And so one thing I'll say that I think is the coolest thing, honestly, about being a physician is that you can take that expertise and apply it in so many different ways. And it's so powerful. And so although I truly love what I do think that there are unique things that I'm interested in that I feel like potentially I could contribute in those areas more uniquely. Let's just say I am working on culinary boards as well, because I want to be able to kind of fill in that last gap of, okay, yeah, I understand what the concepts are, the categories, but what does that look like when you're doing it in the kitchen? And I'm really interested in what that looks like from different cultural backgrounds.
Welcome to Roots of Healing, the podcast where we uncover the stories, insights, and visionary ideas shaping the future of lifestyle and integrative medicine. I'm your host, Dr. Siri Chand Khalsa, a physician and advocate for holistic healing and embodied living. Please note that this podcast is for educational and informational purposes only. The views expressed by our guests are their own and do not constitute medical advice. Please consult with your healthcare provider for personal medical concerns. Each week, I have the privilege of sitting down with trailblazers and thought leaders who are reimagining what it means to heal mind, body, and spirit. Together, we're exploring their journeys, innovative approaches, and the deeper roots of healing that inspire us all. And this week, I have an absolutely delightful guest, Dr. Rashmi Kudesia. She is a lifelong learner, and we're going to hear about all of the journey in her educational process. At this point, and I hope this inspires you, our younger learners in your clinical journey, Dr. Kudesia is a triple board certified in reproductive endocrinology, infertility, OBGYN, and lifestyle medicine. She's been caring for patients at the CCRM Fertility Houston since 2018, and she's had multiple annual clinical recognition awards. She serves as the Director of Patient Education and Sugarland Site Director, the Assistant Clinical Professor at the Houston Methodist Hospital. Bravo! But there's more. How did she get here? Well, she graduated magna cum laude from Brown University, where she got her MD with honors. Brown was undergrad, and then MD with honors from Duke University School of Medicine, and then OBGYN residency at the New York Hospital Weill Cornell Medical Center, and then her REI fellowship at Albert Einstein College of Medicine. Wow! And then in the mix there's a Master's of Science degree in clinical research methods. She served as a clinical assistant professor at the Icahn School of Medicine at Mount Sinai, as well as the medical director of Brooklyn office of Reproductive Medicine Associates of New York. She's a fellow and active member of the American College of Obstetricians and Gynecologists and has served in multiple local and national leadership roles. What got you interested and excited about medicine?
So the medicine part, I would say, was a childhood thing. My dad's a physician. He's a cardiologist. And so, I grew up kind of being in the backseat of the car with patient pamphlets strewn about. And so, I knew what cardiac catheterization was and angioplasty was, in middle school, just having, at the patient level, kind of having read those and sitting in the backseat just bored, so that was kind of what I grew up in, that environment. And I was really interested in a lot of the things my dad said. I just loved how he talked about his job, kind of meeting all these interesting patients, and he was always so passionate about it. And I loved science, so that seemed like a no-brainer. But I think the more interesting part, like you said, as a kid, you kind of meet your pediatrician. In my case, I had an ophthalmologist as well. And so for many years, I thought, okay, ophthalmology, that's what I want to do. Just because, like you said, 2 or 3 things you kind of know about. And then I went to college. And my freshman year, I had just the privilege of taking embryology with an amazing professor, Anne Fausto Sterling. She's retired now, but the fascinating thing about her career was that she's a hardcore, bench science researcher, but then also very interested in science studies and gender studies. And so really, when we talked about embryology, we talked a lot about the social context, and really what that means, is kind of how science affects society. And I think we're living in such an age that's bearing that out, right? This intertwining between science and society. But, in the early 2000s, when I was, kind of first delving into this world, that was kind of an interesting new lens for me, kind of thinking about that interplay between how science, what we decide to research, what's worthy of research, and then also how that science, that development plays out in technology and how people experience that. And so, what specifically I became interested in is in assisted reproductive technologies, or like IVF, in vitro fertilization, and just infertility treatment in general, and what that ends up meaning for sort of the lived lives of women with infertility. And what was fascinating about that was previously people had infertility, they were just told they were sterile or barren, which are like these horrible words. And then that was just it. Either you were childless or you adopted or whatever, but there were very limited options. And so then, as we began having all of these infertility treatments, increasingly, I think up until the point of now, there started to become more and more pressure to then pursue those treatment, right? And so it's like, okay, well, now it seems like it's treatable, so if you have infertility, then why wouldn't you just do however much it takes, to have that baby? And it's not always an easy journey. And so I think, that to me was really fascinating, as a young woman, kind of thinking about, wow, this is this huge identity crisis for people thinking their entire lives, hey, I'm going to have a kid. And then the time comes, they might have been spending 10, 15 plus years trying to prevent pregnancy. Now they're ready to try and it's not happening. And there's this whole identity crisis that happens there. So there's this fascinating piece of that. And then now there's all this availability of treatment, but access to it is very limited. It's expensive. There's not great fertility clinics in smaller towns and rural areas. And so employment based coverage is different from state to state, and so there's just all of these different gaps. And so that was the part that I really got interested in is okay, well, how does this impact women and people just in general, but primarily people who are going to potentially be pregnant, and so what does that mean? And so I got really fascinated in that. Started doing some courses in the gender studies world, sociology, anthropology, looking at how people view pregnancy across the world, and then kind of arrived at medical school thinking, well, if I actually like the clinical practice of this specialty, then that's what I want to do. And so it was a little bit backwards because I was really interested in the higher kind of level of it from sort of a philosophical perspective, and then fell backwards into it in terms of the clinical practice, and that piece of it just ended up being great. I love working with my patient population. They're really generally folks that are very highly motivated to succeed, generally young, healthy-ish, although all of us could always do better. I'm sure we'll get into that in a minute. But, so anyways, that was kind of the way it happened, I guess.
That's incredible. I always call it like the sacred thread, if you will, that really becomes so apparent in the retrospectoscope, like when we can really look back and see the weaving of our interests and our the call that sits inside our heart.
Yeah.
And I think Brown is such an incredible place for, I grew up on the East Coast, and I always think of Brown as being this very thoughtful place where philosophic paradigms are being explored, where it's not all just being taken for granted. And to have had such a beautiful female mentor, which I might add, late 90s, early 2000s, it still wasn't dime a dozen female mentors. Like, to find an accomplished female scientist, not to say they weren't there, but to find someone who then also ostensibly took you a little bit into the fold and
Sure.
offered insight and perspective. What was your major? Just out of curiosity, what did you major in, biology or anthropology?
No, I did end up doing biology for a variety of reasons, but I debated doing so at Brown. We do have the ability to kind of create your own major, basically. Mm-hmm. And I thought about essentially doing like a science studies kind of concentration where it would have been kind of a mishmash of what I was just talking about, essentially.
Yeah.
And then the long story short, the only reason I didn't was because I wanted to do some basic science research as part of my thesis, and it just ended up aligning better with the sort of traditional biology degree. Yeah, but I definitely thought about it because there are a lot of opportunities to sort of shape all of that the way you want it to be.
Yeah, it's so amazing. And then Duke, of course, is a very rigorous academic institution. I went to school in Virginia, so I'm very familiar with Duke.
Yeah.
And how did you find, you came in with a certain direction and passion. Did you find medical school nurtured that? Or was it tough to sort of hold that vision? I think one of the hardest things, and I know we'll have med school and younger trainees that listen to the podcast. And I always like to encourage, like, my first year, my M1, what would I tell her? I came in with a vision about doing integrative medicine in 1998. So, like you,
Yeah.
I had taken a couple years off and I'd studied yoga and herbology. And I was, well, I think I'm going to go back to medicine. I got a master's degree and circled back, but it was hard to hold the vision of that. What was your experience like that with?
Yeah, I think that's a really insightful point. Is that it is, I think, hard during medical school sometimes to latch on to what even through residency and just kind of postgraduate training too, what that ultimate job is going to look like. And you really have to hang on to that when you're sort of in the grunt phase of school and training and all of that. And for me, I would say again, I kind of got lucky. So I really just cold called the division director of reproductive endocrinology when I got to Duke. I emailed him and I said, "Hi, Dr. Wilmer." Dr. David Wilmer was the division chief at that time. And I said, "I'm a MS1, just started, but I'm really interested in reproductive endocrinology. Can I come hang out with you?" And it turned out that not only did he say yes, fortunately, but he was a very awesome mentor, because I think the thread for me is people that it's not clinical medicine, but I think it's like medicine and. I've always had so many mentors that were kind of the traditional path and something else. And I think that has always attracted me. So in his case, he was very religious. And so he did reproductive endocrinology, which is sometimes criticized, or fertility medicine criticized as being sort of taking care of the people that can get to your office basically, right? Because of those gaps in care. But then he was also doing a lot of cervical cancer screening in Haiti and like all kinds of other things. He was active in the divinity school. So he was doing all kinds of cool things. And so he was just a really eye-opening kind of guy, and made me realize that, again, I could pursue taking care of these patients and having that specialty, which he loved and I love, but then also serve in other ways. And so that was great. Yeah. So I basically hung out with him, shadowed him for however many days, weeks, months. He ended up being one of my thesis advisors as well. And so, I worked with him for many years, but that was really how that happened. I just went in and cold called someone. And I
Right.
think that that's really helpful. And interestingly, I don't know, I'm not currently on any medical school admissions boards or anything like that, but increasingly I hear that there's a lot more emphasis for prospective medical students on shadowing or scribing or that kind of a thing. And, I think I always wonder, is that the best use of time? I think when we were in those phases, it was like research and this and that, which is still important, but I do think that having that clinical experience, whatever role it is, of being in the office and seeing what that's like, that actual day in, day out, is really important, because again, that's what 99% of physicians are going to do, not research necessarily. And so I think it is really helpful to have sat in those rooms and be able to say, yeah, this is the conversation that I'm willing to have tens of thousands of times, because that's what it ends up being, right? Is that you say
Right.
the same thing a million times, probably like 10 times a day at least. And so you have to really love saying it and getting
So
into it.
true.
Yeah. If it's not a conversation you want to have again and again and again, then it's going to get boring really fast. And so I think that's really the thing that I found, is that I was like, wow, this is really interesting. And it's an honor, I think, when people come with their reproductive journey, because they're really willing to share all kinds of things. Literally just met you, and then they're talking about some of their biggest hopes. They're talking about their sexual intimacy. They're talking about all kinds of things. And it's really, I think, a privilege to be able to sit in that space. And so that was something I realized, very early on. It's a really intimate, sacred place and relationship. And so that's kind of how that played out.
Oh, it's beautiful. I think it's so important to just pause and acknowledge that it also takes a confidence in self and a trust in self to make those cold calls, that you can show up for simultaneous things at once. Not everyone believes in themselves to that extent, and you could probably credit all kinds of different sources along the way. When you jumped into your OBGYN residency, was there early on the ability to sort of niche into the reproductive aspects, or was that really, you really just had to get all of your basic OBGYN under your belt?
No, we could. And I mean, I was, again, sort of fortunate in the sense that Weill Cornell is where a lot of historic discoveries in our specialty have been made. And so there are a lot of big names, historic things that have happened there. And so it's a very busy, active infertility unit. And so, yeah, definitely was able to kind of jump in and have some faculty mentors that were willing to kind of help and sort of walk me through that process. And then a lot of the fellows that also kind of help and want to take a resident under their wing and sort of guide you along the ropes and things like that. So yeah, I mean, I think it was a good place to be in that regard because it's, like I said, a very active place from an infertility perspective. And so definitely got to observe a lot of things. And so again, for some folks that may be doing residency where there's not an active infertility program, it's a little bit more theoretical, I guess. But
Yeah,
we
I would
definitely got
imagine.
to see that, very concretely, kind of from the early stages of my residency.
That's amazing. Good on you. Like, I can really sense that vision you had. And I want to just again mention that sort of sacred thread that some clinicians have that I think gets this really developed area of expertise, like incredible areas of niche knowledge that make you an expert in your field. And I can really imagine that the fellowship, the Reproductive Endocrinology and Infertility Fellowship at Albert Einstein probably started to solidify. But again, we know there's just the beginning, right? That was the
Yeah.
conversation. Did you have a particular area of research that you delved into? Tell us a little bit about that.
Yeah. So, I mean, I think, as you said, I think sometimes you look back at your life story and you get to a certain age, I guess, where you can think that maybe you do part of a life story. But I think when you look back, you can see certain things that even if it wasn't the way you initially maybe planned it or whatever, but, kind of it was just one step on a puzzle, right? And I think for me, doing my residency and fellowship in New York City ended up being very central to my thought process and my career because I had the opportunity. We had in residency and then multiple in fellowship, we had city care based fertility clinics. And so we really did have the opportunity to take care of folks at every sort of place around along the spectrum. And that I think was really important because you can sort of see how that becomes very different. The advice you can give someone with very limited access to care, limited health literacy, maybe just limited, English proficiency, the way you can explain all of that to someone, even, I'm not even talking about just the language because most places will have, interpreter services and that. So, it may not be the same as being able to have a conversation, with someone in their native language, but, regardless of all of that, just the amount that you can explain, and sort of how to
Right.
help someone on one hand versus the people that walk in the door and they're like, I want to do IVF tomorrow. It's like totally different. And so what I started getting really interested in because of those disparate experiences was sort of two things, I think. One, and it took me a long time and I had two fellowship program directors during those 3 years. And I remember my first program director was always like, you are interested in too many things. Like, this is not going to work for you. You need to. And I'm like, well, I don't know which of these to get rid of, And it took me a while, actually, post training, I think, to see where it all came together. And actually, I think where it all came together is sort of in lifestyle medicine, but that wasn't really a thing, or it was just beginning to become a thing at that time, but I wasn't even aware of it then. But anyways, what I think ultimately began to get interested in is one, sort of patient education, which I think was a direct kind of growth out of what I was saying before about sort of the lived experiences of people dealing with infertility. And so it's kind of like, okay, why do people get to a certain point and never even understood how their menstrual cycle works? Or at that time when I was in fellowship in the early 20 teens, there were early to mid 20 teens, there were all of these articles that kept coming out in the Times and the Post and this and that, article, magazine, paper, whatever, about, oh, I never knew this. Like, no one told me this. And so there was just beginning to become this explosion where people were talking about fertility and infertility and IVF. And it was a really interesting time, to be kind of interested in why is it that people get to their 30s or 40s and only then realize, hey, if I want to have children, this is the window or this is what I could have been doing. And then at the same time, regardless of what sort of resources someone has, what are the baseline things, foundational things we can do to not only be healthy but then have a healthier pregnancy and a healthy baby? And so thinking about sort of that epigenetic concept of, okay, when you're healthier before pregnancy, then you have a better chance of having a good pregnancy, those genes getting turned on and turned off in the right way for your baby, and then sort of gifting your child this lifelong gift of their best possible, health that they can start off with, right? And I think that's like a cool concept that people are generally not aware of. And so those are the things I started to become interested in. And, there's like a lot more nuance to that, but
Sure,
that's
absolutely.
really, I think, kind of the thread that has been kind of weaving itself through all of this, and where I am now is really preconception health is, and lifestyle, and optimizing that is really the thing that I'm probably the most passionate about, because I think it can be applied in any setting. It doesn't require necessarily the most sophisticated, expensive treatment or technology. And so it feels like there's just a role and a potential for it to be equitable in a way, or to actually even advance equity, right? Because, you can sort of say, well, there's only so much we can do to equalize access to IVF for certain things, but everybody in theory can be given the knowledge on how to have a healthy pregnancy, in a way that they can actually digest. And so that's kind of what I'm interested in now.
That's incredible. And I think my own career, I had a 3-year break where I studied Ayurveda with Dr. Vasant Lad
Yeah.
in Albuquerque. And while we were there, we actually did a fair amount of discussion around preconception.
Mm-hmm.
And what's interesting is that it really beautifully parallels the things you're talking about in terms of the micro decisions that someone is making create this macro experience. And so all these little micro choices of diet, movement, connection, sleep, stress reduction, harmful substances,
Yeah.
and I think sort of spiritual health, financial health, these other pieces. And interestingly, in Ayurveda, which is more abstract, is how the energy of the parents combine.
Mm-hmm.
Again, this is not always something people plan for. Of course, there's so many circumstances where pregnancy happens, but
Right.
I have some very dear friends that did a panchakarma program, which is sort of like a internal reset and very cleansing fasting with prayer and deep devotion before they conceived their child. It was very deliberate. And she had worked for years as a doula and massage therapist. And so she had, she's got family in Houston too. I'm thinking I should connect you guys, but that's another story. But I found that the thread of that is so interesting because, like you, she believes in that personal empowerment to women is the key to opening so much more. It's easier for a healthy child to learn if given. There's so many layers: empathy, learning, cognition. All these things come from perhaps decisions that are being made in seemingly a vacuum right now. Like we're putting so much emphasis in one arena where we could really just be saying, wow, what if we put all our efforts towards these preconception time and really help people understand. Small also aside, we have a family member who's got a chronic neurologic issue. And it was so interesting talking to them recently, and they shared there'd been a new impaired fasting glucose. And I had said, well, what do you think about how that might be affecting this other process?
Yeah.
And there was a little disconnect. Like, I didn't know that those two could be related. I just saw them as one lane and B lane. And I imagine even just something as simple as impaired fasting glucose could have a significant impact on pregnancy. I don't want you to feel pressure to reference an article, but like, can you share with us perhaps some seemingly obscure lifestyle things that might actually have data, or that your lived experience would say this is something to really pay attention to in the preconception time?
Yeah, absolutely. And first of all, I totally want to echo what you said, because one of the things back to the things you say all the time, one of the things that I often tell people and try to encourage them to think about, as you said, not lane A and lane B, but I'll often say, like, in Western medicine, we have this tendency to sort of silo, right? If you have a stomach problem, you go see a gastroenterologist. And if you have a heart problem, you see a cardiologist. And if you have a brain problem, you see a neurologist, whatever. But that's not really how the body works, right? And every Eastern medical system has always intuitively understood that. And I think what is powerful about lifestyle medicine is that it tries to get back to that ancient knowledge that we all had, right? There's no Western, Eastern, whatever, but there's no ancient medical school of thought that really believed that everything was separate. That just doesn't even make sense, honestly, right? And I've never had any patient that wasn't like nodding along as I'm saying this. Like people all intuitively understand that our body is connected, and in a weird way, we're rediscovering that, if you want to call it now, right? So like this microbiome brain connection, for example, not my area of expertise, but all of these things. And so that's one thing I do tell people all the time, because they're like, oh, well, do I really have to worry about my autoimmune disease? Well, yeah, I think you should, because if you have inflammation running rampant in your body, first of all, how does that feel like it's the right time to have an egg release be inside of that same body, and then, turn into a pregnancy, and then you're growing a baby for 9 months in that environment, where if you have all of these, elevated levels of inflammatory markers running through the same bloodstream, that's then going to nourish that baby for 9 months. How could you possibly think that that's going to be, it's not beneficial, right? At the best, you can say maybe it's a neutral, but I would say in many regards, the concern is that maybe some of these things are, more harmful than we realize. And when we're out there trying to wonder, why is it that, we have higher rates of all kinds of problems nowadays? I think a lot of it is an interweaving of all of these issues. It's kind of like, how are we eating? What are all of these things that we're going into our body that were never meant to be inside of our bodies? And so how are we responding to that? Sort of the higher levels of stress, because of, again, all of the societal things, et cetera. So, I think that to me is a very plausible explanation for why our health is declining, and in child health specifically, fertility and child health. And so some of the things that have been demonstrated to be beneficial, for sure, from a dietary perspective. And I think what's interesting is that, people come in and they're interested in like fad things. They're like, oh, I read, if you eat a lot of pineapple, that's going to help. And good news, bad news, you don't have to eat a ton of pineapple. That's not going to do anything. So that's the good news.
Yeah.
But the bad news is that if you really want to be optimizing egg and sperm quality, and hence set yourself up for an early pregnancy, then whole food, plant forward diet, the same thing we recommend for everything else, is where it's at. And, you can call it whatever. You can call it Mediterranean diet. And I think oftentimes people think that means you're eating Mediterranean cuisine. And I always also say, you can do Mediterranean diet in every cuisine under the sun. But really, we're trying to hit those, kind of nutritive food groups, getting more vegetables, fruits, healthy fats and proteins, and just kind of minimizing junk food, fast food, processed food, right? So whatever that looks like from your country of origin, if there's a specific food, kind of food or cuisine that you like with whatever spices, but that's kind of what we're trying to do. And so being, in the US, being in Texas, right, it's kind of an uphill battle to think about less junk food, fast food, processed food. We spend a lot of time in our cars. We're driving by, fast food all the time. It's a very hectic lifestyle. And so, that's the thing I try to encourage people. And sometimes, people may already have children. And so I always tell my patients that are already parents, like, just imagine how you wish your kid was eating perfectly, because we know toddlers don't eat perfectly, but just now that you're sitting there thinking about and obsessing about how they eat, try to feed yourself that exact same way. Right? Because why do we worry about that with kids? Because we want to give them the best sort of foundation to build upon. We're trying to make sure we hit all those food groups, eat the rainbow, but sometimes we don't turn around and apply that to ourselves. And again, data all across the world sort of substantiates that can make a difference. We don't have to be perfect, but even moving a little bit in the right direction, like, moves the needle. And so you can get improvements when we follow those things. And so that's kind of what I try to tell people. And one last nuance to that, the other reason I tell people is because I think sometimes, again, and I know that Eastern medical traditions, Ayurveda included, like you said, have this sort of unique way of envisioning sort of how egg and sperm come together. But a lot of times I think in the US or the Western context, people don't even think about sort of preconception at all. They think like, okay, once I'm pregnant, then boom, I'm pregnant, and all the other stuff is kind of out the window. Like, all that matters is what I do now, which is, there's some nuance to that. Yes. If you really turn things around and made big lifestyle changes, then that would be good. But it's hard to do. If anyone that has ever been pregnant, the first trimester is not the easiest time to make any of those changes. And so, I try to remind people, you feel
not recommended.
Yeah, not, I mean, it's very hard. You're exhausted.
Yeah.
You feel nauseous. You oftentimes just want to eat carbs all day long. And that's fine. I'm okay with people doing what they need to get through that phase. I did it myself. But the point is, if you can sort of buffer that with a healthy lifestyle before, and then as you feel up to it later on in the pregnancy, kind of building those ingredients and blocks back into things, then that's a good way to do it. But it's not like you can flip a switch. Okay, I'm pregnant, so now I'm going to be super healthy. That's just
Mhm.
not how it works, basically.
Yeah. Can people come to see you for a preconception visit? Is that a insurance billable visit, or how does
Yeah,
one set that up?
yeah, it is. I mean, the insurance industry is purposefully very complex.
Elusive,
And so,
yes.
in general, it can be kind of confusing. But yeah, it is. It is something that we can do. And sometimes it just depends how we bill it and what
Yeah.
the plan covers. But, there's even just completely out of pocket pricing for just the conversation. And then, if someone wants to do labs, and sometimes for whatever reason, again, opaque stuff that I can't fully explain. But, if their primary care doctors are ordering the exact same stuff, then sometimes it gets covered. But if I order it, it's not, so
Right.
we try to
I
play
do
that
get
game.
it.
But
I've been there.
yeah, exactly.
And I wonder, I want to come to your book in a second because I think
Yeah.
it's a beautiful segue, but we still haven't sort of made the pieces of how you got to Houston. So you were working as a
Yeah.
clinical assistant professor at Mount Sinai and
Yeah.
medical director of the Brooklyn office
Yeah.
of the Reproductive Medicine Associates of New York. What happened? How'd you get to Texas?
So I met my husband.
Ah, yeah.
Yes. And he is a Houstonian, born and bred. Yeah, he actually grew up down the street from the office that I ultimately came to open here
Oh,
in
wow.
a Houston suburb called Sugarland of all things. But yeah, so that's what happened. So he was also living in New York at that time.
Mm.
I'm originally from the Midwest, and so we are both kind of middle of the country people. We wanted to have more space and kind of a different pace of living to start our family, and so we were looking to move back somewhere. So yeah, so that was kind of something we had in the works for a while, thinking about coming back to Houston.
Yeah.
And I really do love it here. It's a super, super diverse city, and just so much good food, so much good culture. I mean, there's just a lot going on here. Almost, it's about to be, I think, in the next couple of years, the third biggest city in our country.
Wow.
And people are still so unfamiliar with it in some ways.
That's
But
incredible. Now,
yeah,
when you made that transition, did you decide? Again, we're talking for the female entrepreneurs in
yeah,
medicine here for a second. You own your practice, or are you part of a group? Tell us a little bit about what's happening from that standpoint, because I have a
yeah,
sense of what's happening. You're very capable. So tell us a little
yeah.
bit about what that looked like.
Yeah. So when I was looking to make that change, I was like some years out of fellowship. So still really early career at that time. And what is interesting about reproductive medicine is that there are multiple components to um, kind of how successful you can be in terms of what you can offer your patients. And so, what I mean by that is that have your physician, and a lot of times people will have someone that they really vibe with. But then, when it comes to IVF, for example, a large part of it is really what's happening in the laboratory,
Hmm.
and so there's where you marry sort of that art and science and medicine piece of it, right? Because what I say is, you could take a physician that you may love, but if you put them in a place where the lab is kind of mediocre, they're only going to be able to offer you certain success rates. And a similar embryo in one lab versus another could have, half of the success rate, depending on various circumstances. So we're not talking about small numbers here. We're talking about pretty big differences in quality and success. And so, for me, I think one of the big things I was looking for is, going somewhere where, because we had a little bit of luxury of time. And so I was like, all right, I was working at a place where we had an amazing laboratory, and I was like, I only want to make sort of at least a, sort of lateral
Collateral,
shift in
if
that
not
regard.
better. Yeah.
I want to be able to feel that if patients come to me, I can confidently tell them, if your embryos are going to grow somewhere, if you're going to be able to grow high quality embryos, I do believe it can happen in our lab. And I love bragging on our embryologists and our scientists, because I had nothing to do with any of that. It was is already sort of there. And kind of like I was saying about Cornell. Now that I'm at CCRM, it is a place that our main office is in Colorado. So it stands for the Colorado Center for Reproductive Medicine. And a lot of groundbreaking IVF discoveries have happened. And so it is, there. And so it is really an honor to be able to kind of have that access to those folks, to that kind of lab excellence. And like I said, I can brag on them all day because I have nothing to do with it. But that was really the main job that I was kind of considering ultimately. And so it just worked out that I had a friend that was already in the group and some other connections. And so it kind of just worked out. And then again, they kind of had this idea of opening in this suburb that turns out to be very heavily South Asian. And, and then I showed up and I was like, well, not only, am I also South Asian, but my husband literally grew up there. So I'm very familiar with this part of town
Yeah.
and would love to practice there. That's kind of how it worked out. And it was great for me because it's also, we do a lot of the teaching for various residencies and medical schools in the area. And so I do get to still do a lot of academic stuff. But kind of have a really nice setup in that regard. So that was kind of how that all happened.
I think it's so incredible. And if you're open to it, I'd love to hear your perspectives on the South Asian experience of not having children, because is it different? Is it the same? I have some ideas about this because we weren't able to have kids. And of course,
Yeah.
I don't want to dive all the way into that. I had a really different experience with my South Asian family than I did with my, I guess you could say, white family. The family I grew up in, which is from really different headspaces. Can you talk about that a little bit? Do you think there's a difference, or do you notice a difference?
I mean, I definitely think there's a difference. And I think it's not necessarily, I mean, I think there are a lot of immigrant cultures that are similar. I also take care of a lot of African patients that tell me very similar things about if we can't have children together, that really makes me feel like potentially as a daughter-in-law coming into the family, right? So first of all, there's these very traditional notions of, sort of these patriarchal notions, I guess you could really call them, but they're very long lineage of, okay, there's sort of, you marry into a family typically of the man, right? So I mean, this is all very heteronormative, of course, right? But and so then you're sort of this daughter-in-law, you kind of come into the situation. There's a lot still, even in the US, of folks that have joint family structures, so they may live with the husband's parents or whatnot, or very close to them, or in the same house. And so then there's all this pressure of, okay, well, if I can't provide grandchildren, then, is my role even warranted in this family? Or what is my role in this family? And so there is a lot of pressure. Absolutely. I think that, that is definitely there. And even in families that are more contemporary and sort of their way of thinking, but some of those, I think ideas, do exist. And there is sometimes a little bit of a residual feeling of, well, we also have to have a boy to carry on the name, even though many people don't even change their names after marriage anymore if they get married. So that's also kind of an outdated one. But, I think that there's just a lot of things and a lot of pressure. And in general, I would say many South Asian families are very enmeshed. And so whereas for many people, I mean, I've, had many people tell me over the years, oh my God, like, why do you even talk to your parents about this stuff? I'm like, well, I don't know how not to, I mean, it's a very different situation. They tend to be very up in the business of everything. And so, where I think European cultures are oftentimes much more polite, if you want to call it that, or, they're afraid of offending. And, there's different pros and cons to everything. I think, sometimes that can create distance, but then sometimes people want distance, so there's no one size fits all. But long story short, I do think that there is a unique aspect to that. And last thing I'll say too, is that when you grow up in a culture that's not very open around sex and sexuality, then I also think that creates issues. And then talking about those things, in terms of, okay, well, are we, is there any issue on the intimacy front? There are actually really high rates of pelvic floor disorders and vaginismus and stuff in South Asian women. And so I think there's a lot of sexual intimacy problems and sexual dysfunction that's probably underdiagnosed. and under researched as well, honestly. And so I think there's a lot of unique aspects to that. But I definitely think that the enmeshed kind of component of the pressure from the in-laws, in my experience, I see that most from South Asian families and African families, like where they're literally coming from Nigeria or Ghana or whatever in recent generations, and they're telling me, well, my in-laws are telling us even things as extreme as you divorce her and move on if you're not going to be able to have children, and so that is just really hard. And then you're in this culture where people are like, oh, you can't get pregnant, just relax, it'll happen, which is the worst thing, by the way, to say to someone that's
Worst news
struggling.
ever.
Worst
Well,
thing ever.
I think too, we could have like a several hour discussion on this. Like there's so many threads here, but I think even just nuances in how marriages were arranged in one generation back, like my husband's family, a number of those relationships were arranged marriages that of course have their own subtleties and explorations and beauty. And I think I have become really a good ally for understanding and communicating some of these concepts because I've had such a unique lens of exploration. Tell us a little bit about your book. And I want to also point out that you might be one of two lifestyle medicine REI clinicians. Is
Yes.
that right? Like
That I know of. Yeah.
yeah, what a
Yeah.
beautiful niche. That is
Yeah. It is.
incredible.
Yeah. So basically, going again, sort of like a thread through this conversation is that patient education piece. And so it was kind of a beautiful confluence of things. So I had my oldest daughter in 2019, and she was around 6 months when COVID happened. And so she was kind of, a baby, and that was like a weird time to be a first time mom. And then at that same time I got approached to write this book about, sort of explaining fertility awareness. And so sort of getting into okay, if someone's trying to get pregnant, they want to understand how to facilitate that or make it more likely to happen. Let's write, an updated book from a physician perspective on that topic. And I was like, yes, because, our sort of patient volume kind of took a big dive at that time. People obviously weren't coming into the office. A lot of people were like, thinking about putting their pregnancy plans on hold until we had a better idea of what was happening. So that was all very understandable. And so kind of had the time. And so, so that was my other COVID baby became the book. And so that was just a great experience trying to make it really. So there are obviously other books with similar concepts out there, but one of the things that I have found, and perhaps the most popular book out there on that topic, is that in some senses a lot of it feels very anti-physician, and I'm sure you experience this too, right? There's this kind of this stereotype of what a doctor is in this country anyway, and if you try to be something different than that, then you kind of, I think, feel a little bit hurt by some of that. Oh, if you see a fertility doctor, they're just going to tell you to do IVF and that's it. And there are plenty of fertility doctors where that's probably a fair thing to say, but that's really not how I practice. And so what I felt in some of the other books was that there was this sort of like, it almost felt like a failure if you needed to actually go see a physician. And I wanted it to be the opposite, where it's like, look, you can spend the time, you can do what you can at home and really try to arm yourself with all this knowledge. But then here are situations where, first of all, I skip the queue, kind of go straight to the front of the line, go see someone now. Because I see people all the time where they think that they've been trying for years. And then I go through their menstrual history and I'm like, wow, you probably haven't been ovulating for most of this time. And how frustrating is that? A guy that's taking testosterone therapy probably doesn't have any sperm production that's going on. And so then there's that whole, so there's many conversations where I'm like, well, you probably should just go in first and then we'll circle back and think about different options. But that was really the mentality that I wanted to write that book with, was, okay, we're going to be realistic in terms of not making the doctor option seem scary or a failure, but empower people to do their best, kind of on their own, if you want to call it that, and then seek care when appropriate and try to arm them with how to come into that appointment most, sort of ready to succeed, I guess.
Oh, that's incredible. I'm curious. I've definitely been, excuse me, hearing some data, and it feels perhaps even a little sensationalist. So this is what I would love for you to weigh in on. Are we seeing significant declines in fertility? Is that actually happening? Or is it just how data is being managed? Or is that a real
Yeah.
thing?
I mean, I think there's a couple different factors that are coming together. So I do think that there is data on, for example, declining sperm quality. That seems pretty accurate. Now, I mean, the reality is that, for example, eggs and sperm, totally different biological approach, right? So for sperm, really there should be tens, hundreds of millions, of which some percentage are going to be moving, and an even smaller percentage, really only about 4% by our strictest criteria, are going to be normal under the microscope. So there's going to be, tons of bad sperm for every perfect one, basically. So totally different evolutionary perspective compared to an egg, where typically you're only releasing one egg every month. And so it's all about the quality of that egg, right? There's no like, okay, well, we're going to release a whole bunch and let the best one win. That's kind of what we do in IVF, actually, is try to grow a bunch of eggs at the same time and see which one can actually develop. But at any rate, so where I think, uh, then moves the needle forward is, okay, well, if sperm parameters are looking worse over time, is that enough to create an actual problem? And so that, I think, is a harder question. With women, the question is, okay, well, first of all, people are having children later. So the actual prevalence of infertility is going to be going up because, whereas perhaps in previous generations, if someone happened to get pregnant with their fourth or fifth kid in their 40s, then they were fine. But if they didn't have that, they would also have been fine, right? They already had however many kids in their 20s and 30s. And so you wouldn't be diagnosing infertility, in this age range of 40s plus the way that people do now. And the only growing age cohort of women trying to become mothers in this country is women aged 40 to 44. And a lot of those women are going to have infertility. So I think there's kind of a combination of more people trying to have children in a way that is less likely to be successful, and then larger parameter of factors that make it more difficult. Say with regards to like body size, as we all know, BMI is not the end all be all of anything, but at kind of either end of the spectrum, too low or too high, there can be definite impacts on, ovulating, on getting pregnant, on miscarriage rates, and things like that. And so complication rates. So, I think a lot of the trends in that direction over time are contributing. So there's many factors, I think, that come into it. But long story short, I think that some of it is good. Some of it is people trying to wait, be more thoughtful on, do I really want to have a child with this partner? That kind of a piece of it. And sometimes that means waiting until you're a little bit older, which is where, the potential for fertility preservation and egg freezing and stuff comes in. But, so some of these trends are, I think, in a way good, kind of like what you were saying about previous generations. People just were like, okay, put together, and now you go forward and figure it out, So things have changed, but I do think that, I do believe that because of deterioration of lifestyle, preponderance of chemicals, endocrine disruptors, microplastics, I just don't see any way in which that could be good. And even to think that all of that is net negative or net neutral, I think, to me, that feels a little bit hard to believe, no matter whatever someone may tell me. And I think there's plenty of evidence that sort of suggests that microplastics in the placenta, probably not good, but we're finding it there. So those are the things that I kind of think are probably all part of it.
It's such a complicated story. And what I love about your perspective, which reminds me so much of my own Ayurvedic background and primary care, is that it's never the same person twice. Every person is such a unique amalgam of variables and wishes and hopes and dreams and thoughts and stressors and biologic exposures and age and where they live. And all these things have this elaborate weaving. And I think that that's so beautiful that you innately relate to people like that. And I think that that probably does really help your work to stand out. When you meet someone who's dealing with infertility, what do you think is one of the primary fears that they're sitting in, and what do you like to tell them when you're sitting with them?
Yeah, I mean, I think, and I know you've had this journey, and so much of this, I know you can see from the patient side and the physician side. But first of all, from the physician side, I think that one of the difficult things about this specialty is that we have a very binary outcome. Either people have a healthy baby or they don't. And it doesn't matter if they made beautiful embryos in the lab. It doesn't matter if they implanted but then all miscarried. None of that stuff ultimately matters. So it's not like when you're taking care of diabetes, when it's like, okay, your A1C your sugar levels overall, at least a little bit. That's at least a little bit of something. That doesn't apply in this specialty. It feels very all or nothing. And if you don't get to the finish line, then for many people, at the end of the day, the rest of it doesn't really matter. So, at least as an outcome, how you took care of them along the way does. And I do think that I've gotten a number of messages from patients over the years. The ones that probably make me cry the most are the people that were not successful actually, but wanted to take the time to write and say, the way you and your team took care of us through that journey is something that we'll always remember. I mean, that's really something, and so to answer your question, I think people's fear, is that they either, a deeply desired goal of them, to be a parent or to grow their family. I mean, sometimes even they may have a child or multiple children, but they really want one more to feel complete in some way. And it's just evaporating in front of their eyes. And it's a very, I don't know, it's a very deep, deep urge. And not to say that you have to have children. Many people do not have that urge. But for those that do, not being able to see it realized can be incredibly devastating. And then it's constantly triggered. Other people are getting pregnant all around you. You go on social media, everybody feels like they're pregnant. And then people are always asking, they're up in your business, right? So it's just really hard to get around it. People are always curious. Oh, why don't you have kids? And honestly, I experienced that myself. When I moved from New York to Texas, I was in my mid 30s and people were like, how come you don't have kids? And I was shocked at how many people asked that. But culturally, it was really different than New York City. In New York, people are much more likely to ask you about your career or your hobbies or whatever. And in Houston, and I love it now, for where I am in my life now, but it's very family centered. And so people will constantly be asking, oh, do you have kids? How old are your kids? They just look at you and they see you're married. How old are your kids? I'm like, whoa, we have a dog. So anyways, all of that is really tough. And so ultimately, what I try to tell people is to take the sort of emotional aspect of it as its own sort of grieving process and deal with that appropriately. And we have resources for that. But to try to look at the disease as just any other disease. You wouldn't look at someone that got, diabetes or heart disease and say, well, oh, you're less of a woman because you got this thing. And so trying to take some of that stigma out of it and some of that self-judgment and that voice in your head that's like, well, we should have tried earlier. If I had just met my partner earlier, it all would have been different. So trying to sort of help people get at the heart of that negative self-talk that's coming in is, I think, the idea. Yeah. Because there's just so much of that in this. So that's what we try to work on.
I love that. And it's a very holistic perspective. I think it's so important to recognize that if it can't come to being, it's okay to get a lot of support to help you through that. Yeah. And usually, and I'm here to say it's okay on the other side.
Yeah.
Honestly, you can. And for those of you listening that may be still in the middle of that grieving process, I'm just here to say that you can find a lot of meaning and purpose and rework the thoughts you had about what it needed to be or what you thought it would be, or even what other people's perceptions about what made you valuable. Those are all malleable. They can all be worked on and explored, and you can be joyful and find a great life. So I'll just leave it to that.
Yeah.
If someone is thinking, this will be our last question, if someone is thinking about getting pregnant and they want to look at a preconception process, what's a reasonable time out and who should they talk to?
Well, I would always encourage someone to start with their primary care doctor or their OBGYN, whoever they have, and hopefully they have one or both of those things. So if not, then that's one good thing to try to identify, especially in OBGYN, potentially that would deliver the baby. And so you want to be looking at which hospital, is it the hospital you want to have your baby at, hopefully, and do you really vibe with this person? You're going to trust them with this super important health journey. And so talking to them about that, and if you don't get good answers or if you feel like you have concerns that aren't being fully addressed, then either a second opinion or coming to see an actual fertility specialist, particularly, if you're older or if you feel like, which in theory would be kind of like mid to late 30s or beyond. I don't want someone who's 38 to be, wasting time, and having misconceptions that aren't addressed. So, but basically I would say that The notion is pretty simple. You want to, be tracking your cycles, kind of try to get a good idea for a 3 to 6 month timeline before you maybe potentially want to be pregnant. Are your cycles coming fairly regularly every month or so? Do you notice any symptoms that would suggest ovulation? Is your general state of health fairly good? Are you trying to aim for that whole food plant forward diet? Are you watching alcohol, cigarettes, that kind of stuff? Are you trying to get your sleep 7 to 8 hours? How's your stress level? Who's there around you in your support network? Those kinds of things. Get on a prenatal vitamin with the right amount of folic acid. And so pretty much anything that says prenatal vitamin will have enough. So those are kind of obvious things, but those are the foundational things. If someone's on birth control pills, oftentimes I'll tell them, especially because many of us were on it for 10, 15 years before maybe we wanted to have kids, and that's fine. There is no negative aspect of that. But what that means is you have no idea what your cycle is. And so I often do tell people maybe come off of it for 3 to 6 months, use a barrier form like condoms if you're not ready to be pregnant, but give yourself that time to observe your cycle and learn kind of what your body's doing. And then as we dive into it further, if someone wants to be doing ovulation tests and stuff, they sure can. But that's kind of the beginning stages, is really just preparing your mind, making the space in your life. And oftentimes people push back on the lifestyle stuff. And, I don't have time for this. I don't have time for that. I get it. Believe me, I'm also very busy, and I was incredibly busy before children as well. So I get it. But on the other hand, if you want to bring a child into your life, you're going to require a lot of space of time, and that's not going to come out of nowhere. And so I do try to tell people, look, if you think that you're going to be able to do all of these things and then potentially be pregnant and then have a baby and nothing is going to change, that's not how it works. And we might as well try to create that space now. And then to whatever you believe in, hopefully you're just sort of telling the universe, signaling, hey, I have the space in my life for that now. And we can hopefully get it to work out. So that's how I try to tell people to think of it in that regard.
That's so smart. And it's really that process of discovery, right, for each person. So our last little piece here is that one thing I think that's so unique about your practice and where you've settled and the community you're serving is that if we pulled a classic lifestyle medicine handout, the food might not resonate with them, right? The flavors, the presentation. And you kind of said, well, we can do Mediterranean diet with Indian cooking, but I'm curious, I think you're going through a culinary medicine certification.
Yeah.
Do you have any plans to have a culinary teaching kitchen or a blog? Those are so fun. And what a beautiful bonus to really bring it into their own hands. Like, hey, come to the kitchen.
That's partly why I find you so inspiring, is because when I look at what you achieve in the kitchen, it's just so impressive. And it is absolutely sort of a goal of mine to grow in that way, because I think it's part of that physician journey. And you were talking about potential learners that could be tuning in. And so one thing I'll say that I think is the coolest thing, honestly, about being a physician is that you can take that expertise and apply it in so many different ways. And it's so powerful. And so although I truly love what I do think that, there are unique things that I'm interested in that I feel like potentially I could contribute in those areas more uniquely, let's just say. And so, yeah, absolutely. And so I am working on sort of culinary boards as well, because I want to be able to kind of fill in that last gap of, okay, yeah, I understand what the concepts are, the categories, but what does that look like when you're doing it in the kitchen? And I'm really interested in what that looks like from different cultural. I'm very sort of familiar, obviously, with Indian food. And so I could sort of do that in that regard. But there are other foods that are other cuisines that I'm not that familiar with. And I do, like I said, I take care of people from all over the world. And, I think it would be really fascinating to be able to more intuitively help people understand that, just like simply, like, what does this kind of a healthy plate look like? Wherever you may be from, and so again, the specific proteins or healthy fats or seeds or nuts that we might choose could be a little bit different depending on where we come from, but the elements are all there, and every ancestral cuisine had those elements there, right? It's helping people reconnect with that and sort of not having sort of a ton of super processed rice is the main thing that they're associating with their cuisine.
Barfi, the sweet treats and the desserts. We just were at this baby showers, it would be, and there was a gift of box of Indian bakery sweets. And My husband always gets like completely gooey with sweets. Like he can't even think. And I told him, he's like, oh, we forgot the sweets. And I'm like, it's okay.
Yeah.
Well, it's okay. They'll wait. They can be frozen and you can have a little here and there. But
Right.
some of the ways in which diet has evolved are not necessarily nutrient dense, and it's oriented to sugar, salt, or sweet.
Yeah.
And of course, those metrics internally tend to take us towards metabolic imbalances, unfortunately.
Right.
And I love this notion of really being an innovator. That's one of my favorite values in physicians, is just innovating and seeing where there's niches and philosophic spaces to live in to bring more synergy, more insight. And it's been amazing to talk to you, Dr. Kudesia. I think your patients are so blessed to have found you. And tell us where people can find you and how they could work with you in what states you're licensed in. We may have someone who's like, I'm traveling to Texas.
Yeah. So right now I'm primarily seeing patients through my practice in Texas, and that's where I've kind of let my other medical licenses lapse. So that's where I'm active. We know we do offer telehealth, so I do see patients from all over the state. And I do take care. I mean, honestly, I do take care of people all over the country and the world. I mean, sometimes people will come in for care or whatnot. So I'm always happy to do a consultation with anyone over telehealth. But ultimately, particularly if it ends up being some like IVF kind of journey, then people need to travel to Houston a couple times for those key components of the care. But yeah, my practice is through CCRM Fertility Houston. And that's where I primarily see patients. And I'm happy to take care of anyone that, again, especially if they're passionate about these topics, there are not a lot of places where people are equally excited to talk to you about them. So that is definitely a unique area of kind of what I'm interested in.
What a treasure. And we'll have links to your practice, your book, and your other resources that you would like to share in our show notes. And thank you again for taking precious time away from all your important clinical work. It's been a delight to meet you today.
Thank you so much. Likewise.